So my third lecture, my third topic in this interesting event will be about isotretinoin management, which is a topic that I like very much and I study a lot. And we're gonna talk about, we're gonna discuss with you our opinions from both sides of the Atlantic. I'm here to represent what we do in Brazil. No, my disclosures, no conflict of interests. The objective is discuss with you what has changed in the last 40 years or 41 years, as we know that oral isotretinoin was approved in USA in 1982, in Brazil in 1990. So we started using this drug in Brazil in 1990, and we have a huge experience with this drug. I'm going to talk about those lab monitoring adverse events, talking about the common adverse events, the controversial adverse events, the severe and the major problem, and I'm going to show you some cases. You know that oral isotretinoin, despite being introduced 42 years for 2 years later, it maintains as the gold standard treatment for acne. It is the treatment that promotes the better impact on quality of life, as we have the chance to cure the disease. As it targets all etiologic factors, it's highly effective, and this long time of its use showed us that it is a safe drug. It prevents bacterial resistance, which is a very important problem regarding the wrong use of antibiotics for acne. So nowadays, we should indicate this drug as early as possible. There is no reason anymore to delay, except if you have an absolute contraindication. But of course, the major risk maintains the teratogenicity, which we should pay attention. This is the first publication from me and my professor. At this moment, we have used the drug for 26 years. So we already have a good experience. And here you can see many recent publications, including one from 2021, 2021, 2022, 2020, many publications, recent publications, especially reviews, practical prescribing about oral isotretinoin. Regarding daily and total dose, we know that what we see in the label, in the insert package of the products, was established 42 years ago based in just 2 studies about the ideal total dose for remission. It was not very good. They were not very good studies with a very low level of evidence. And after so many years of its use, nowadays, there is a consensus that low daily doses should be preferred, about 0.3 milligrams per kilo per day, to complete resolution plus 1 to 2 months, which means that we cannot consider the total dose that is stated in the label, which means 150 milligrams per kilo, because we see patients that cure with less than this and others that needs much more. So the optimal total dose depends on severity. It varies a lot among the patients. When we use low daily dose, sometimes we need to prolong the duration of the treatment. In this case, we should pay attention in women, because because of the risk to be pregnant. And after the treatment, after clear completely the skin, 1 to 2 months more, and then topical maintenance treatment for 6 to 12 months. This is very important to reduce relapses. But if we see a relapse, if you have a relapse, we can introduce the drug again, and we can do many cycles as necessary. There is no limit. About the relapses, there was some discussion that low daily dose should be related to higher risk of relapse. But this study showed that the relapses are associated with severe and extensive acne, young patients, familial history, and women over 25 years old, especially when they have hyperandrogenism like the PCOS. But the main cause for relapse is when the doctor stops the treatment in the presence of inflammatory lesions, because he follows what is in the insert package, in the label. So when the patient achieves 150 milligrams per kilo, the doctor stopped the treatment. And if the patient still has inflammatory lesions, the disease will recur, of course. In this study, with 1,400 patients, the second treatment was necessary in just 20% of the patients. This is the considered rate of relapses. After 12 months to 5 years, we can see relapses after a long period, and there were no difference related to those. This is very important. About lab monitoring, many studies, including systematic review and meta-analysis, showed that there is no evidence for monthly monitoring and for a huge number of tests to be done because they are rare. They occur early in the first 6 to 12 weeks of the treatment. Usually they are mild, transient, and reversible. Especially in teenagers. These data are from studies with teenagers. So the lab monitoring should be more economic. We should just ask triglycerides and transaminases, just these nowadays. This is the consensus. At the baseline, after 2 months, and of course, if necessary, if you have any increase in these tests. About common adverse events, I think everyone knows very well the mucocutaneous, which are predictable, controllable, and mild when we use low daily dose, which promotes better adherence to the treatment. It's very important to control, to avoid the mucocutaneous adverse events by starting in the first day of the treatment, the use of lip balm, moisturizer, eye drops, nasal saline solution, and sunscreen. We should pay attention to ocular alterations because sometimes they are not observed and underestimated, and they can be severe. About the controversial adverse events, many important and very good observational, special case control studies with a very good methodology showed clearly that there is no association of oral isotretinoin with premature epiphyseal closure. So the drug can be prescribed at any age, even for prepubertal acne. There is no risk of abnormal healing, hypertrophic scars, and keloids. So we can perform surgeries, laser, microneedling, chemical pills during the treatment or as soon as we finish the treatment. And there is no risk, no association with inflammatory bowel disease. There are other causes for this disease, like the use of antibiotics and the acne. Acne as a chronic inflammatory disease can be the cause of inflammatory bowel disease. It has nothing to do with the treatment with by oral isotretinoin. And about depression and suicide, we know very well that these problems are associated to adolescence and to the disease, to acne. We can see mood changes when treating acne patients with any treatment. There is no psychiatric contraindication to use oral isotretinoin, even when the patient has a history of depression that is controlled, or even when he had a history of suicide attempt. This is a very important publication from 2023. I recommend its lecture. The authors included 24 studies investigating completed suicide attempt, suicide ideation, self-harm, and depression. They included 1,606,009 and about 900 participants, so a huge number of participants with an average age from 16 to 30 years, so they included also adult patients. They found a rate of suicide and self-harm less than 0.5%. Depression 30.8%, which is very similar to the general population at this age. Among isotretinoin users, they were less likely to suicide attempt when they look at 2, 3, and 4 years following the treatment. The isotretinoin were not associated with risk of any psychiatric disorders. So at population level, isotretinoin users do not have increased the risk of suicide or psychiatric conditions, including depression. They have a lower risk of suicide attempt after 2 to 4 years from the end of the treatment. Of course, as we can see, mood changes. It's important holistic psychodermatologic care and monitoring of patients for signs of mental distress, because this is very common during the adolescence and in acne patients. Here is our publication about a pilot study when we performed the medium depth chemical peel in the whole face, followed immediately by manual dermabrasion in the area with atrophic scars. We did in a group of patients, and we didn't see any problem with cicatrization, no hypertrophic scars or keloids, even in this patient phototype 4. So we agree that there is no risk. Nowadays, there is consensus that lasers procedures for treatment of acne are safe, including hair removal. And about treatment of acne scars, many recent studies showed better results when the procedures, which means fractional ablative laser, microneedling, dermabrasion, and chemical peels, we can get better results when the procedures are associated with low daily dose of oral isotretinoin, like 10 milligrams a day, as we can do when we do the treatment. At the end of the treatment, after the skin is clear, we can maintain for 1 to 2 months, and this is a good moment to start the treatment of scars. About severe adverse events, they are the flare-up and the acne fulminans. The flare-up, we need to have the feeling that it can occur when we see a patient with severe and extensive acne, especially lesions on the inflammatory lesions in the trunk, many macrocomedones with familial history of severe acne, male and very young. In this case, for prevention of the flare-up, which has a very terrible impact in the quality of life and can cause scars, For prevention, we should start the treatment with very low daily dose, about 5 to 10 milligrams a day for 4 weeks, and then we can increase or not. I prefer not increase the dose, maintain the dose until the complete clearance of the disease. And we need to add prednisone 0.5 milligrams per kilo per day for 4 to 6 weeks until we see an improvement of the inflammation. Acne fulminans is another adverse event because it can be or not induced by isotretinoin. And we can see acne fulminans with or without systemic involvement. And the approach, the management is similar to the flare-up. The major problem of oral isotretinoin, of course, is the teratogenicity that can occur with any dose. This is the unique adverse event which is not dose dependent. All the adverse events are dose dependent. This is one reason as when we use low daily dose, we see less adverse events, but teratogenicity can occur with any dose. So the contraception is mandatory by using one safe method. The monthly beta-HCG dosage also mandatory. It's very interesting when we look at the literature about this topic that there is variable adherence to recommendations to avoid pregnancy all over the world. And we see less worry in Asia and Middle East. And also we see failure of preventive programs. For example, in the USA, still are reports of pregnancy during the use of the drug. In my opinion, this is caused by the poor relationship between patient and doctor, and also because of another very important problem, which is the possibility to get oral isotretinoin by the internet without prescription. This is real. We can also see with comparative studies when they compare the use of oral isotretinoin versus the association of oral antibiotic plus topical fixed combination, usually adapalene plus BPO or benzoyl peroxide. They usually treat the patient for 3 months and show no difference between these two treatments. Of course, we know that isotretinoin sometimes starts the improvement of acne after 2 to 3 months. So they stop the treatment when the drug would be working better. And we know that the antibiotics, they promote an early effect. So there is a bias in this conclusion. This is a study about the use of about this comparison using doxycycline, 200 milligrams a day. It is strange, and also for 5 months, as we know that antibiotics should be used for just 3 months. They showed early effect of the combination and an improvement starting in the 2nd week, but isotretinoin was better after 20 weeks, of course. And the adverse events were less frequent, 50% less frequent with the combination, because we see it's very common. We see in almost 100% of the patients, we see, for example, dry lips, and this is considered an adverse event. So authors concluded for no inferiority, this treatment is, of course, an alternative to isotretinoin when we have, as I've said before, absolute contraindication. In all these studies, they don't do follow-up, so they do not analyze the relapses rates. Some cases, this is a boy, 13 years old, 3 previous treatments with other doctors with oral antibiotic by fixed combination with early relapses after the end of the treatment. He came to me, I put him in skincare always, oral isotretinoin for 6 months. I didn't see any serious adverse events until complete resolution. Then he was maintained with adapalene at night for 1 year. And now after 10 years follow-up, no relapse. Here you can see the good result. We don't see results like that with any other acne treatment. Another patient, this is from our university. If you pay attention, we can see that this patient have had scars at the beginning of the treatment, but they were early scars, erythematous scars, and they completely disappear with oral isotretinoin. So I believe that oral isotretinoin can treat recent scars. This is a very severe case. Just on face conglobate acne, this patient needed 2 years of treatment to get this result. This is another patient, a boy, 15 years old. He came to me because of this flare-up after the introduction of oral isotretinoin and regular daily dose without prednisone. This patient has familial history of severe acne, his father, extensive disease. He was very young, many inflammatory lesions, mostly just inflammatory lesions, especially pustules. So I put him in oral isotretinoin 10 milligrams a day until complete clearance plus 2 months. But I add prednisone for 6 weeks until improvement of the inflammatory status. There were no adverse events and the complete resolution, as you can see in these pictures. But these patients relapsed after 3 years. This is expected when we treat very young patients with severe acne. So I put him in the second treatment. In here, you can see the results. And now he is under scar revision. We are performing microneedling, laser peeling, many procedures to restore his skin. Here you can see in this area, temporal area, he presented atrophic scars because it was heavily affected by the flare-up. And here I'd like to call your attention to his facial expression during the first consultation with the flare-up when he was very young, and nowadays how isotretinoin has changed his life. This is another very severe case, a boy, 16 years old, with acne fulminans, induced by oral isotretinoin prescribed in regular daily dose without prednisone. This patient presented systemic signs and symptoms, secondary bacterial infection in the lesions, and needed hospitalization. We put him in a very low daily dose of isotretinoin plus prednisone plus cephalosporin, and he got, in 15 days, he got this resolution of the disease, of course, with a lot of erythema. But unfortunately, there was an evolution to hypertrophic scars and keloids that we are now treating pass by pass. And this evolution occurred without any procedure. We didn't perform any procedure in this patient before. So this was related to the disease. So my take-home messages are, we should think as in an early and most effective treatment when we're talking about acne, especially in teenagers. We should think about quality of life. We can have psychological repercussions for all life in the patients with a long term of acne. We should, for girls, association with hormones and oral isotretinoin, and we can associate oral isotretinoin plus spironolactone plus contraceptive. Consider oral isotretinoin as much as possible. Attention to teratogenicity, of course, and our mission is treated to cure our patients, and we have a drug that can cure. So we learn with each patient. But again, I would say that success depends on good doctor-patient relationship, as acne is a very chronic disease and take time to improve. Thank you very much for your attention. And again, I thank my team from my university.